Hello, I'm Stephen Gilbert. I'm Professor of Medical Device Regulatory Science at the Dresden University of Technology in Germany. So I was asked to give an invited talk, so a longer keynote kind of talk at SEMANTiCS this year, which I did earlier today. This is the first time I've attended SEMANTiCS, but I've really enjoyed it. It's been a great event. So I think the impact of the combination of machine learning and knowledge graphs could be transformational in medicine, and the combination could help to address a very important limitation in some machine learning approaches. So I'm thinking particularly of large language model approaches, which are deep learning based and have limited underlying or no underlying model of truth. And the linking of these technologies, which are highly creative, highly wide-ranging in their ability to answer medical problems and address medical questions in dialogue models, in chat models, in decision support systems, needs to be linked to truth models in some form. And actually I would be slightly bouncing off Aidan Hogan's keynote presentation from this morning. A really nice illustration of how that can be done in practice. The area that I work in is in the regulation of healthcare, so looking at the need for doing that. I talked in my presentation about a recent paper we published in Nature Medicine, looking at the limitations for large language models application in medicine, the need for when they are applied in medicine, that they're taken through quality and regulatory frameworks. Within that paper, we talked in a low level of technical detail about possible approaches for that, and those include medical specific large language models, which are still deep learning based large language model approaches. They still lack a model of truth. And we also talked in a very low level of technical detail about the possibility of having further secondary model layers which apply models of truth. I think Aidan's talk went a really long way in illustrating how that could be done, not in the medically specific domain. He addressed this from a general domain. And I think that's a critical question. An aspect I tried to bring out in my talk is the importance in understanding that this may be a partial process, and that it's really important within large language model approaches and knowledge graph approaches and in approaches which bring those technologies together to understand the degree of different contextual uses, different intended purposes of technologies, but also different uses of them in a medical context, and providing information to clinicians, to physicians who are often in a decision-making loop, which is labeled in the degree of certainty of outputs produced from these models and in the degree of risk. And even within our research paper, and I mentioned it briefly in my talk, in having the ability of triangulating information from different sources. I think it's critical within these technologies to enable the human in the loop, in the medical domain, generally the physician in the loop, by equipping them from models with data to equip their decision making in a broad sense, in a holistic sense, the human being the center of the holistic decision-making process, but also being fed data which is very specifically and intelligently curated to assist them in their decision-making process from one or multiple sources. And this question of integrating and quality labeling multiple sources of data to enable the central decision-maker in the loop, I think, is one of the biggest questions for the integration of machine learning and knowledge graph approaches in medicine. Medicine and healthcare is one of the areas which is achieving lots of excitement in the application of knowledge graphs and large language models. My dream would be that this is done in a manner which actually looks to the the important human questions for healthcare systems. Sometimes there is this relatively backward idea that somehow the application of these technologies can speed the medical consultation, that we just have decision support systems, information structuring systems. We can provide those as an assistant tool to clinicians, and then they may be 3 minutes faster in a consultation or 4 minutes faster in a consultation, and that we can have patients forced through the consult room at a higher rate, and this will provide greater efficiency to the healthcare system. My dream would be an acknowledgement that the implementation of these technologies needs to be very, very carefully thought out in providing human value in the entire healthcare system to patients and to doctors and to healthcare providers holistically, understanding the challenges all are under. It's not all about technology. It's really, the biggest challenge we actually face is not about what the next technology will be. It's about how we bring those technologies into society. In my presentation, I quoted an article from the Pew Research Foundation about how we will see the best and the worst in the transformation of digital life from technologies of this type, AI technologies and particularly large language model technologies, in the period between now and 2035. And I echoed this article, and I actually made the additional point that's even with care and with regulation and with concern for ethics. If we don't get regulation right, we could be in a situation of seeing a lot more of the worst of the impact of these technologies on the lives of citizens, the professional lives, and not seeing very much of the best. So we really need to work to get the regulation and the implementation questions correct. If any healthcare system buyers, healthcare system organizers, the senior managers within healthcare systems and healthcare system procurement, healthcare system planning are thinking about this from a very narrow technological perspective. We can replace this, we can manage demand in a relatively narrow way without looking at the big picture, without really considering how they're going to look to enhance the entire delivery of the care system. They're going to get this wrong. And there's the consideration of how the human will work within the loop, the physicians will work within the loop, how the physicians will react with patients, how the reaction and the interaction of physicians will be changed by these technologies is critical to getting this right. There are very interesting work, which I didn't quite get a chance to mention in my presentation, about new models of the layers of decision making that can happen with models of this type, perhaps giving an initial form of decision making, which then can be referred to a clinician, a little bit like they used to refer to a senior clinician, as part of a new form of decision making loop. This is published by other researchers in the domain I work in. And another concept that's been published by other researchers in the field I work in is the concept of having a quality unit, a kind of transformation unit for AI within hospital systems. And I would actually even see within wider care systems and national health systems that actually work to make sure that these technologies are integrated in a way that works. They measure it. They always start from the position, the assumption that introduction of a technology will make things worse more easily than it makes it better. They don't start, it sounds crazy, but you don't start from an ultra technology enthusiast position. You start from a degree of skepticism in bringing technologies in. You measure effects, you properly resource the measuring of effects. That's expensive. It takes workload away from delivery. You need to correctly resource that in order to get transformation right, and transformation which is useful for people. And some of my own work, which is about to be published, actually looks at building systems for the measurement across technologies, the measurement across decision support systems as they're introduced into healthcare, providing loops within the technology itself for providing, for gathering feedback from patients, gathering feedback from care providers, exploring how the new technology makes their life, stress, worse or better, exploring from the patient whether the new technologies have actually enhanced things or not enhanced things, the technologies are transformational. They're in the digital transformation space. We need a parallel, and I would argue linked, digital transformation of the measurement of the effect of the technologies in a very holistic way. If we have kind of a concept, these technologies are clever, they're very advanced, and then we kind of just throw them over the wall of implementation, throw them into the wild, the effects will be more bad than good. I have the perspective that we kind of have a balance or a seesaw in how these technologies can affect society and specifically healthcare systems. They can make literally everything worse if that balance is not right. On the other hand, they can make literally everything better. And it's a question always of monitoring and showing care in the introduction and measuring it. And what we will see, it's a little bit like I mentioned from the Pew Research paper, they will bring both the best and the worst, but we can't just say, well, that's fine. We need to look at individual specific implementations and explore the extent as we implement those that they're bringing the best and the worst. And we need to feed back into the implementation and into the reaction with the care providers, with the nurses, with the doctors, with the other healthcare providers, and with the patients, detailed exploration to get that always moving in the direction of better and not in the direction of worse. I have a concept, maybe as a last point, that this idea that AI will save money in the healthcare system is kind of the false starting point. It should be much more a look of how AI can enhance care. There should be a moratorium on thinking on money saving through AI. Maybe in 20 years it will. In the very initial steps, it will cost more, and it will actually create more challenges in the introduction of AI and getting its implementation right. And having a shift away from this concept of AI as a means to force more patients through quickly and a kind of sausage factory approach to an understanding that it's going to be a more expensive question, a more challenging role for doctors, as I talked about quite a lot in my presentation, a very challenging situation with the liability of doctors, a more challenging decision-making role for doctors where they have not only to deal with their own intuition on what's wrong with the patient, they have to deal with the intuition of an AI. They have to bring these questions together, and they're in a very difficult liability situation. That's actually a harder job for doctors. Doctors need to be prepared for that, and the technologies need to support them and be regulated to support them in those questions. The highlight has been to, I wasn't able to attend yesterday, so I'm going just from today in SEMANTiCS. And the highlight has been watching the initial talks from the morning. So I mentioned Aidan Hogan's talk, which was the keynote, which was really inspirational. And also other talks in the parallel sessions that I attended, and seeing how they interact with, and they had similar themes to what I was going to present later in the day. And that there's similar thinking and similar ideas and similar problems that are coming up in many people's work and in even in companies' implementations, and then reflecting on those in my own talk were highlights. Also discussing, sometimes I have luck who I happen to sit beside when I go for lunch. The conversation I had just before over lunch with people working in non-healthcare sector, but in areas of better regulation through technology, better communication around regulation, the consideration of how technologies can bring regulatory understanding and actually bring better regulatory processes was also really interesting as a lunch conversation and new contacts in this area.